Our first presenter is going to be Matthew Smith from the University of Michigan.
Hi everybody, thanks for coming to the talk this afternoon. I know post-lunch on the second day is a little risky to be presenting, but thanks for your time. Today I'm going to be talking about the preliminary effectiveness of virtual reality job interview training for individuals with severe mental illness that are enrolled in individual placement and supported employment services. My disclosures are I have no conflicts of interest, and the study I'm going to be talking about was funded by the National Institute of Mental Health. So we know that severe mental illness and employment don't necessarily go hand in hand. There's an extremely low employment rate, about 20% at a national scale in terms of individuals with SMI that are competitively employed. And we know that for folks that are engaged in supported employment services such as IPS or the individual placement and support, that rate increases to 40 to 60%. Although that's still really low compared to the national employment rate. Now, one of the core components that individuals really need to engage in before they can get employment is the job interview. You know, it's the most proximal factor to getting a job. You know, and that's the same whether or not you're engaged in IPS services or whether you have no services, right? And the job interview is an anxiety-provoking the thing that everybody does, not necessarily just for individuals with severe mental illness. And so we could ask ourselves, what is the gold standard in the field right now for training job interview skills, right? And the short answer is there's really no evidence to support a standard practice. But what's out there is more or less a vocational counselor, and in the case of IPS services, an employment specialist, this is somebody that will sit down with a client and engage in 1 to 2 mock interviews, give them a little bit of feedback, and that typically takes place before a real-life job interview. And that's about it. And the way I like to think of it is the job interview is more or less a concert of social skill, right? There's a lot of different things that need to go into it, yet can you really enhance someone's skills with 1 or 2 practice sessions? I'll just kind of let that question lie out there. But basically, there's a dearth of evidence-based practice for job interviewing, and because of that, my team and I developed and have begun evaluating virtual reality job interview training. The tool was developed with funds from NIMH, and here's just a quick video to describe the tool. So go ahead and open the link.
Last job interview go? Do you wish you could go back and change your answers? What if you could?
Hello, thanks for coming in. My name's Molly. What can you tell me about yourself?
Meet Molly Porter.
Hello, Molly.
She's hiring for a new store, and she wants to interview you.
What are your long-term career
Molly will
goals?
help prepare you for your next real interview.
Do you have any experience working?
She'll ask you different questions based on what you tell her, just like a real
Do
interview.
you have any skills that might make you stand out from other?
You can practice lots of interviews until you get it just
What
right.
was your biggest academic achievement?
While you talk to Molly, you'll have a coach to help you.
I was really proud when I started my first college-level class.
Interactive educational materials prepare you for your interview, teach you common interview questions, provide tips and hints on appropriate interview procedures, and teach you how to fill out a job application. Scoring gives feedback on how to improve next time. Molly.
Okay, and so I just wanted to give a brief clip because that does a better job than me sitting here and talking about it, whereas we don't have enough time to do a quick demo. As he's going back to the slides, basically after we developed Molly, we had the opportunity to conduct 5 randomized controlled trials to evaluate the efficacy of Molly in a lab setting across several different groups ranging from schizophrenia to autism, including veterans with PTSD. And essentially the story is the same across all 5 RCTs, and that is that our trainees, as compared to controls, were more likely to improve their job interview skill, as well as they were twice as likely to obtain employment within 6 months. And based on that pilot data, we knew that we had to take the next step and evaluate whether Molly is effective out in the real world. And so because of that, we pursued funding and were awarded a grant from NIMH to conduct a hybrid type 1 effectiveness preliminary implementation RCT. And today I'm just going to talk about the preliminary effectiveness results of that trial and really focus on some between-group differences between our trainees and our controls. And just to give some setting, we basically were delivering the tool within the standardized supported employment services called IPS, Individual Placement and Support. So this is really IPS plus Molly or IPS as usual service. And so our primary outcomes were interview skills, employment by 6-month follow-up, whereas our secondary outcomes were just general social skill, interviewing anxiety, interviewing motivation, and interviewing self-efficacy. In terms of our methodology, we worked closely in the spirit of community participatory research with a community advisory board as well as a scientific advisory board who provided direct input into how we were going to deliver the tool as well as our design for collecting data, which is just a traditional pre-test, deliver the tool, post-test, follow-up type of design. In terms of how we decided to deliver the tool, our partners, we determined that we would do a centralized computer lab, and our partner was Thresholds in Chicago, Illinois. Thresholds is the largest community-based mental health service provider in all of Chicago. And we basically determined geographically a centralized location where their clients could come and use the tool. An employment specialist who is the boots on the ground for IPS services was trained to teach the clients how to use the tool. And basically after you interview with Molly once or twice, you can just kind of do it on your own. It's a very simple tool once you learn how to do it to use it independently. And then after doing that initial orientation of the tool, the employment specialist took a step back and said, okay, I'm no longer providing these clients in the study with mock interview training. So we're going to remove that component from their job so we could do some cost effectiveness types of analyses later on. And clients basically worked with the tool for about up to 6 visits. And we expected them to complete 3 to 4 interviews with Molly per visit, and each interview with Molly takes about 25 minutes or so. And then after that initial orientation, the clients, when they would go to the lab, received some supervision and some support from other IPS staff. In terms of our preliminary effectiveness results, we so far have randomized 34 participants with 22 that have completed post-test visits at this time. And then we've had 15 participants complete 6-month follow-up. In terms of our preliminary sample characteristics, we don't really see any differences between group except in age, which in all of our other trials didn't really have an effect on Molly, so we're not too concerned about that. But we did see so far that our IPS-only group has a higher rate of more recent employment. And for those in the employment field, you know that one of the biggest predictors of future employment is someone's recent employment. So that's a variable we're going to be monitoring in case we need to covary for that later on. In terms of other demographics, we didn't really see any difference between our groups. Now, in terms of our real-world delivery, participants completed about 11 interviews with Molly, and that ranged from 7 to 15 interviews with Molly. And then the delivery required approximately 6 weeks to complete across all of our participants, and that ranged anywhere from 3 weeks to 14 weeks. Now, in terms of our outcomes, so here we're looking at job interview skills, which we measured with 2 mock interviews prior to the delivery of the intervention and 2 mock interviews afterwards that we video recorded, and then we had raters blindly rate the performances. So when we compare performances between our IPS plus Molly group to the IPS only group, we see about a half standard deviation effect size improvement in our Molly trainees, and that translates to about a 10% increase in interview skill. And then the control group, we didn't really see any effect. In terms of our employment outcomes, so at 6 months, as I mentioned, there were 15 participants that had completed the 6-month follow-up. And what we're finding is that 1 of 7 of the IPS-only participants was able to find a job versus 3 out of 8 in our IPS plus Molly group. And that translates to about 14% versus about 38% in our groups. In terms of our secondary outcomes, so social competence was something we were also monitoring, and we didn't really see any change in our MOLLI trainees, but unexpectedly we see this interesting decrease in social competence in our IPS-only group, and we didn't really expect to see that either. This was more or less like a neutral measure that we didn't expect to change at all. And so hopefully we'll see some regression to the mean as our sample size increases, but just wanted to share that. In terms of job interviewing anxiety, this is actually our largest effect. It's about 3/4 of a standard deviation effect size decrease in one's job interviewing anxiety for our MOLLI trainees versus no real change in the control group. For our measure of job interviewing anxiety, we took a standard measure in the field of public speaking. It's a self-report that's been cited, I think, 300 or 400 times, and all we did was we took out public speaking and dropped in job interviewing. And then we use that measure to assess one's anxiety about the job interview. In terms of job interviewing motivation, so here we see, again, about a half standard deviation effect size increase in one's motivation to go job interviewing for our MOLLI trainees. And then we do see an improvement as well in the control group, although it is a small effect size. Excuse me. And then lastly, interviewing self-efficacy. So here we see that the IPS-only group didn't really change over time, and then our MOLLI trainees, they improved in the realm of a small to medium-ish effect size that translated to about 8%. So sort of trending in the right direction at this point in time. I didn't really conduct any inferential statistics because our samples are so small right now, just 10 and 12. In terms of our discussion points, the real-world delivery. In our efficacy work, we had highly motivated individuals who completed all of their MOLLI training in about a week or so, and they completed about 15 trials in that efficacy work, whereas in our real-world delivery, that took about 6 weeks, and they completed on average, as I mentioned, 11 interviews. Just a little splash of implementation data is that we did have some barriers to the delivery process, even though the computer lab was centralized. What we found was that some participants had to reschedule a lot, and it was interfering with the schedule of our employment staff, for the IPS employment staff. And what we figured out was that just geographically and through the use of public transportation, it was taking the participants an hour plus to get to the computer lab. And so we did have to make a modification on the fly so that instead of using the centralized computer lab, we are now delivering MOLLI straight to more localized provider locations. And so the thresholds model is typically they have satellite locations across the city, and then they do have more central locations. And now we're delivering MOLLI to those satellite locations. In terms of the outcomes, so we basically see a very similar magnitude of effect in our improvement in interview skill compared to our efficacy work, whereas again, we don't really see much change in the IPS-only group. Our employment rate is also consistent with our efficacy studies. In our efficacy work, as you'll see the percentages up there, our controls were employed in the 14 to 26% range, and our MOLLI trainees were employed around 50%, and we're seeing kind of trends in those same directions here in our preliminary data. And then again, the trainees with MOLLI appear to be reducing their anxiety towards the interview, as well as improving their motivation. And again, we see minimal change in the IPS-only group, and we didn't really see any effect on general social skill. In terms of our future directions, obviously we want to complete our effectiveness preliminary implementation RCT. This is just preliminary data. We still have more than a year and a half of data collection remaining, so we still have a lot of work to do. In addition, in the future, we want to develop and evaluate our tool to meet the needs of transition age youth with autism. So that's another study that's funded that we're actively working on. And then in the future, we would like to be able to deliver these tools to adults and youth with SMI that are involved in the criminal justice system. So I just wanted to acknowledge our team. It's a very large team to conduct this work, and I just wanted to thank everybody for your attention.
Okay, Our next presenter is Leisha Ostro from Live and Learn Incorporated. Welcome.
Hi, I'm Leisha Ostro. I run a social enterprise out in California called Live and Learn, and I am also a survivor researcher. So in addition to being a researcher and a business owner, I also incorporate my own lived experience into both of those things, primarily, I think, through relationships with my peers in that community, but also, I think, provide some unique insights. So there is a qualitative component of this study that I'm not going to discuss, but I was reviewing a recent grant application that my team wrote about this project, and I just wanted to share a quote from one of our participants who is a small business owner with a psychiatric disability. I was told, don't have huge expectations for your life. Keep your goals very small or realistic, otherwise you'll trigger your illness. Entrepreneurship is specifically about risk. So people have been continually told explicitly or implicitly that they should not take risks. It takes a lot of mental effort to cast that aside. So, the project has a great technical advisory panel, which consists of people in academia, rehabilitation researchers, other entrepreneurs and social enterprises, other university folks, people providing technical assistance. And so they assisted on study conceptualization, an environmental scan, which is where we got some of this qualitative data, survey design and recruitment, data interpretation and presentation. So I very much employ a CBPR methods throughout everything that I do. And so this project is no exception. And I guess I should say also that I was funded by NIDLR, which is the National Institute on Disability, Independent Living, and Rehabilitation Research. And my project officer isn't here, but I was hoping she would be. So background, as you all know, high unemployment rates among people with psychiatric disabilities, higher than any other disability group, although we do see in other research that these folks express a desire to work, a high percentage express a desire to work. Small business, conversely, is very popular in the US, more popular than most other institutions, including the police, HMOs, or Congress, usually. Now is no exception. 71% of the public, this is from a Pew study, believe that small businesses have a positive impact on the country. You often hear that a lot of new jobs are created from small businesses. And a lot of those are single owner businesses, creating, at least a job for yourself. But we don't really know about small businesses operated by people with psychiatric disabilities, so the intersection of these things. How can the positive effects of small business ameliorate some of the negative effects on employment of psychiatric disability? So I'm going to go over some of the context in terms of the study and objectives, some of the survey results, still preliminary. We're working now on inferential analyses, and I don't really have any to present, but papers imminently on that, and conclusions and future directions. So self-employment is individuals who work for themselves, either as an unincorporated sole proprietor or through ownership of a business. So my business, I'm the only employee technically, but it's an S corporation. There's a lot of advantages, disadvantages to different models. I'm sure that's over almost everyone's head, and that's no exception for people with psychiatric disabilities. There's a lot to learn. Entrepreneurship is a related concept. The Global Entrepreneurship Monitor defines it as any attempt at new business or new venture creation, such as self-employment, a new business organization, or the expansion of existing business by an individual, a team of individuals, or an established business. So the goals of this study were to do, the aims were to do an environmental scan. We did open interviews with 10 self-employed individuals, and then a nationwide pilot survey to identify useful questions, patterns of self-employment, and goals for future research. And I'm going to be presenting today exclusively on the pilot survey results. This is really hard to see from here. It's hard to see there too, huh? So basically what we want to understand, right, is that some people who have psychiatric disabilities are in a regular job, in wage employment, and a lot of them are unemployed, on disability. And then some of those people who are unemployed are going to choose, thank you, Denise, to get jobs, right, through IPS and other things, and some of them might choose to be self-employed. So this study is really looking at that pathway. So there's different kinds of self-employment, right? There's supporting yourself through a job. That's kind of the first step. I think my anxiety about having a business was greatly reduced when I talked to a coach who I didn't end up hiring, who said, The first thing is for you to have a self-sustaining business. Then you can think about employing other people. So I kind of put that in the category of growth-oriented entrepreneurship. So first, we'd have a major unemployment problem for people with psychiatric disabilities. However, I think there's also opportunities with this work to alleviate some of the unemployment problem for other people who may not want to have a business, but maybe they want to work in a small business. And then, we start to see, later on, hopefully, associations with economic growth and, more directly, employment-related growth for this population. So this survey we call the Self-Employment Starts With You, SESI survey, because you're nowhere in this town without an acronym. We created the survey based on existing small business, entrepreneurship, and disability surveys. So there is no, it would have been great if there was already a data set, right, where we could measure psychiatric disability specifically, as well as self-employment or small business ownership. The U.S. Census Bureau, Bureau of Labor Statistics, does a lot of measurement about small business and entrepreneurship, self-employment, and then of course we have a lot of disability-related surveys about, and even disability and employment, but there is no data set that measured those two things. So I had to create one. So we asked people about the characteristics of themselves, their work histories, disability history, previous experiences in employment, as well as their businesses, their budget, things like that, and then their plans and goals for the future. So we ended up with 60 eligible participants. I should say that this NIDLR grant was a one-year fellowship, so it turned out pretty good, I think, with those kind of resources, and it's certainly a good foundation for the future. So those 60 participants, their businesses were mostly focused on healthcare and social services, 20% in training and education, 17% in professional and technical services, and 10% in arts and entertainment. So we did have a full list, based on the codes that are used by the Census Bureau for types of businesses. These are just sort of the top results. It's hard to know, as you know, with non-probability samples, what's an effect in the population and what's an effect of your sampling. I think you could hypothesize that a lot of people with psychiatric histories have these kinds of businesses because of their lived experience, like the way that I do. But it also could just be a recruitment effect, so I don't know the answer to that. So 15% of the sample were under 35, so they were mostly older. 47% were 55 plus. But this is also, again, this is a trend that we see in the general population with a lot of older adults becoming self-employed, and I think some of that is longevity, and some of it is just the state of the economy, the effect of the financial crash that a lot of people's retirement savings were depleted. So this is sort of a trend that you also see in this group as well, but maybe for other reasons too, that people are sort of late bloomers. 1/3 had less than a bachelor's, so they're a pretty educated group, which is not the case in the general population. 83% white, that's also a trend that you see generally, more white small business owners. 83% female, that's the inverse in the general population. So I think about 35% of small business owners in the US are female. But again, we have more people labeled with mental disorders who are female for a number of reasons, different research question. So here we have the comparison. So the blue bars is our study. So these are pretty small. Actually, when I originally created the categories, I used categories that the Census Bureau uses for businesses, and luckily I have that technical advisory panel who was like, you should really measure the very, very small businesses. So we see a lot of those people, a little over 25%, they're grossing, it's just in annual revenue, $1,000 or less. And then we sort of, have this bump at 10,000 to 60,000. This is a totally different pattern than you see. So this is actually censored because 250,000 is not the cap that's, goes into the millions. So we see that's really right skewed compared to our data. So these are really, really small businesses, relatively speaking. But only 23% of our respondents said that all of their income was from self-employment. So they were also getting money from disability, from their family, from retirement, veterans benefits, things like that. And obviously a lot of people living in poverty. Okay, so work hours, a lot of people working part-time in their business. This is not total work hours. We actually didn't ask that, which live and learn, right? So the U.S. Census, you see, is kind of, people working more, and people talk about this, right? Self-employment, you're always on. And you're all like, it's academia, I'm always on. Our population, or our sample is working a lot fewer hours. Again, that might be because they have another job. It might be because they're not able at this time to work more. Maybe they're volunteering. Who knows, they could be sitting around smoking cigarettes and drinking Coke, right? That's a common narrative, unfortunately. But here's an entree into working. In terms of psychiatric history, which everyone had to have to qualify for the study, almost everyone had received outpatient mental health services. This is lifetime. And a good percentage of inpatient mental health services, actually. Fewer with substance use. And then, of course, we have ADA accommodations and SSI benefits on the basis of a disability, those two last ones. So about a quarter of the sample had either gotten accommodations or disability benefits. And the corresponding discrimination. So, you know, it was, I think, fairly normally distributed. You know, about a quarter of the sample had reported sometimes being discriminated against in employment and education. You know, smaller percentage never. Actually, education discrimination, more people said that that had never happened to them. And remember that it was a fairly educated sample. But at the same time, here is the frequency of disclosing their psychiatric history to their clients currently. So there's actually a panel right now about disclosure in the workplace at this conference. So here we see it for entrepreneurs. So 23% always just say they always disclose to their clients. And then you think about the types of businesses, right? There are people like perhaps working in mental health, where we now see a trend with, you know, peer support and all of that, where being out about your psychiatric history can be an advantage. That can get you a job, actually, and maybe it can get you a job as a business owner, too. Here are the reasons for self-employment. A lot of people focused on, almost everyone, on flexibility and freedom. And work-life balance. And so these are also actually the most frequent accommodations that people with psychiatric disabilities request in wage employment, is a flexible schedule, right? Whether that's I need to sleep later because my meds make me tired, or I need to be able to get to my doctor's appointments, or I need to be able to take the train when it's not crowded, or, you know, things like that. Those are the most frequent disability accommodations for this group. And then we also see these are kind of the reasons for becoming self-employed, is getting those kinds of benefits from self-employment. So obviously there are also challenges to having a business. The top challenges were financial management, not surprisingly, personal and family issues, having to deal with taxes, not having the knowledge about how to run a business, access to training and education, which is, you know, an issue more generally, and then legal troubles. Less common were cultural limitations, issues with personnel, and we had a specific subset of questions about what particular issues with personnel, since that's going to be associated with whether you can grow a business or not, compliance with regulatory stuff, and having issues with their disability benefits. So this is a graph of the specifically business-related and social supports that people found helpful or not helpful or didn't use. So the blue bars are helpful, and it's ordered by that. So people found, most people found helpful talking to other self-employed individuals, talking to friends, and using online education, or having a business mentoring or coaching. So you see, like with business mentoring or coaching, of people who used it, that's a really small percentage that said it was not helpful, but there's a large percentage, 30%, that didn't use it. So I think those are kind of the inflection points you always want to look for, right? It's like, what did people who use something find helpful? And then who are the people that didn't get that helpful thing? And then the things that a lot of people use but didn't find helpful, maybe we can sort of move on from. So if you're looking for recommendations for policy and practice, that's always where I look. So here we are with health-related services. So the question was, what services did you use that help you be self-employed? So this is specifically related to self-employment, not just in general. Counseling and psychiatric services is pretty high. Having a spiritual community, mental health peer support, and then massage therapy. So the third and fourth one, mental health, peer support, and massage therapy, there was no one who used it and said it wasn't helpful. But there are a lot of people who didn't use those things. So making those things available or testing them, I think, is important. Plans for growth, blue bars again are our sample, and the orange bars are the general population of business owners. So a lot of people planning to grow. I think that's good. And then, you know, fewer staying the same, similar, or don't know. Making smaller was very small, and then don't know. And that's, you know, kind of the pattern that we see generally. So, and then when we look at their actual growth, we ask them about the change in their revenue in the past 2 years, and the question was asked in more detail, but here, aggregating them, you know, most people wanted to grow, and they have seen increased revenue in the past 2 years, 41%, so it's, you know, on the right track. So, self-employment is an opportunity for those who choose it, just like everything else. It's going to come down to an individual fit and whether somebody wants to do this. I definitely don't think that it's a cure-all. And, you know, there's opportunities, I think, to reduce dependence on public benefits and for community inclusion. This sample in particular, very small businesses, you know, part-time, small budgets, but interested in growing, you know, emphasizing the importance of freedom and flexibility. And then we saw low uptake of commonly available business supports. So people were using coaching and online education and networking. There were fewer people using commonly available supports like the SBDC and things like that. So we're working on analyses related to that. And additionally, I don't have time for this, but I was recently awarded an SBIR grant from NIDLR to develop an online training program. And I have handouts if you want more information.
Okay, our next presenter is Jennifer Humensky from Columbia University.
Do I have to start them? Okay, thanks. Hi, so I'm going to be speaking about education and employment results from the New York State Early Psychosis Program on Track New York. This is joint work with Lisa Dixon. And I also want to acknowledge our analytic team, Aruma, Igor, Leslie, Alana, Jennifer, Scotus, Tom, and Melanie. Also want to acknowledge our on-track sites. We have 21 sites across the state, and the participants, there's 779 represented here in total. I'm acknowledging my funding from the NIMH K01. The on-track program is supported by the state of New York and have no other disclosures to report. To start with describing what early psychosis, first episode psychosis and early intervention. Psychosis is defined as an experience where someone hears things that other people don't hear, sees things that other people don't see. Sometimes it's tactile, feeling a touch or sensation that other people don't feel. The onset, it's incidence of about 100,000 per year, estimated. And the most common onset is ages 15 to 25. So these are the ages in which young people are making their some big decisions in their lives. How much school do they want to go complete? What kind of career do they want to pursue? And this early psychosis will interrupt those plans and that trajectory. Sometimes people are at school or at college and they have to move home. They can't continue college. They have to, if they're in hospitalization, they aren't continuing. They're taken out of their school system, or they have to pursue, on-site schooling within the hospital, within the inpatient setting. And obviously people can lose jobs. Sometimes people are somewhat frightened to go back to the situation they were in before. If I was living in the dorm and I had my first psychosis onset, I don't want to go back and live in that same dorm. Or if I was working, I don't want to go back to that job. Everyone knows me, everyone saw what happened. It's, it's a sensitive thing to go back to. And yet, overwhelming the evidence is that young people want to work and they want to do normative activities. Their friends, their family are working or in school. They want to be doing what everyone else their age is doing. And so it's led to the development of what's called coordinated specialty care, which is a team-based approach in which young people receive intensive services for a period of about 2 years. It's targeted to the needs of the individual, so it's not a strict time frame. Some people are done in 6 months or a year. Some people benefit from more time. But it's a model that varies from program to program. I'll talk a little bit more specifically about New York's program. But here in the US, it typically includes some access to vocational assistance. So early psychosis programs initially developed in international settings, in single-payer settings. They've been shown to be successful in the UK, Denmark, Australia, the Netherlands. I'm probably leaving out some, Hong Kong, Italy. So they've been demonstrated in a wide variety of models across the US. But they were a little bit slower to develop in the US, in part given our fragmented system and the challenges of having sort of, one entity paying for all these different services. But NIMH in the early 2000s supported the RAISE, the recovery after an initial schizophrenia episode. They supported two programs, an early intervention, early treatment study, and the RAISE Connection program, which operated in Maryland and New York. And while those studies were being implemented and while results were coming in like 2014, the SAMHSA made an investment through the Community Mental Health Block Grant, which provided $25 million to states to start their own early episode psychosis programs. And so that was really done even before the RAISE findings were really out yet. But there was enough evidence internationally and there was enough evidence early on in RAISE that SAMHSA said, let's start investing. In 2016, that was doubled to $50 million. So now over 44 states have implemented their own CSC programs. And in New York, the RAISE Connection program evolved into what's called On Track New York. It started off in 4 sites, and it's now up to 21 sites, affiliated with the New York State Public Mental Health System. As I mentioned, the exact model of services varies from program to program. In New York, participants are offered a variety of psychotherapy, medication management, family psychoeducation, and access to supported education and employment services, which we call C services. The supported employment is basically the IPS model, which was mentioned earlier, the individual placement and support model, which is an evidence-based model that's shown improvements in helping young people get back into employment. They further adapted it to include supported education. They've developed some manuals and some tools that basically adapt the principles of IPS into supported education into school settings. And we have a single specialist providing both supported employment and supported education services at each of the sites. So the study aims are really to assess, the On-Track program has been in operation since 2013. What are the benefits, if any, we hope there are benefits, of the C services in the Coordinated Specialty Care Program, On-Track New York, and to examine the association between service use and work school participation and program engagement. We hope that it will promote participation in school and work. We know that, as was mentioned earlier, access to work school participation is low without access to vocational assistance, usually around 15–20% or so. Furthermore, some of the qualitative work in RAISE showed that access to the C services was a key motivator to remain engaged in treatment. And so we wanted to see if that's persisted with On Track and if it's something that we can see in the quantitative data. Vocational services are services that are quite difficult to obtain if outside of a specialized intervention program like this. There are state vocational rehab services which have long waiting lists, and some people have take issue with the quality of the services provided. So having access to a coach who can help coach you through education and employment support is something that's pretty hard to come by. So our participants, a total of 779 have been enrolled from program inception in October 2013 to 2017. There's 21 program sites in New York State. And as I mentioned, there's expected enrollment for an average of 2 years, but the actual duration is going to be individualized based on client needs. As we said, some people are fine at 6 months, some people need more time. So this is just to illustrate the sample. Because this is sort of real-time data, many people sort of enrolled but haven't continued throughout. It doesn't indicate attrition, it just means they haven't been enrolled long enough to receive services. The 4 sites started in October 2013, but sites are starting sort of continually, so sometimes sites are starting new. So that's just to illustrate the sort of the enrollment by quarter. In terms of our study here, we sort of, we'll talk about, we'll look at, when do people initiate treatment and when do, and we look at outcomes by quarter to to adjust for that, but just to illustrate that, decreased numbers does not indicate attrition, it just means people haven't been enrolled long enough. Assessment data is collected by clinical staff at admission, quarterly during enrollment, and at discharge. It's clinical data, we don't have data post-discharge. We look at, we do a random effects model to look at the population average, and we account for within-subject correlations over time in panel data. So baseline demographics, most people are over 18, about 13% are under 18, about 74% are male, 27% are white non-Hispanic, 36% are black, and 28% are Hispanic. In terms of education level at baseline, about 28% are still in high school, less than high school, 19% are in high school GED, 40% have some college, and 12% college or more. Oh, that didn't come out. But at the baseline, participation in work school starts at about 41%, and it goes up to about 70% by 24 months. First-time use of the C specialist. So this is among people who have been seen after baseline, because at baseline they haven't been seeing the C specialist because they've just entered the program. But if you look at all people who came back after, or have been seen after the baseline assessment, about 74% of those take advantage of the C specialist. And of those, almost all do so within the first quarter, the first time use. So the predictors of the use of the C specialist. The largest magnitude of effect is on the baseline education employment. These are odds ratios. People who were not employed or in school at the time of baseline were more likely to use the C, or people who were employed were less likely, had lower odds of using the C services. Likewise, symptoms, people who had better functioning were less likely to use the Cs, or people who had poor functioning were more likely to use the Cs. We also found that younger people were more likely to use the Cs, and this is also consistent with kids who were in high school. It's 100% kids who were still in high school got back into high school, and so we're seeing some of that effect there. And likewise, time from onset to admission, people with longer duration of untreated psychosis tend to have poorer outcomes, and we're seeing here that people with longer duration of untreated psychosis are more likely to use the C. We did not find significant differences in race, ethnicity, or in baseline education, controlling for these other factors. So looking at so taking out people who were interested in employment, and we're just looking at the use of C specialists for supported education on school enrollment in the subsequent quarter. So use of the C specialist in the first quarter on school enrollment in the second quarter. And we find is very high odds ratios. And this is controlling for a variety of characteristics, demographics, baseline schoolwork participation, educational attainment, and controlling for all of those. We basically find that taking out people who were in full-time employment, just looking at people who would be sort of in the sample who might be interested in school, use of Cs for supported education is highly significant with school enrollment subsequently. For work, we only see that effect in the first quarter. So use of C services in the first quarter is highly associated with school employment in the second quarter, but that effect remains positive, but loses significance over time. We also look at effects on engagement. And so this is use of any C services for work or school and use of on-track services in the subsequent quarter. And we also look at, we're controlling for vector of client characteristics, but the use of the Cs is highly associated with use of on-track services in the subsequent quarter, an odds ratio of 4.06. And we don't see that for any other member of the on-track team. No, we don't find significant effects. We look at the number of on-track team members seen in the subsequent quarter, which is a measure of level of engagement. Again, we find significant beta coefficients. Use of Cs associated with seeing more team members in subsequent time periods. We also do see that for nurses, but not for anyone else. So to summarize, the Cs use is associated with improved school participation, work participation in the first quarter only, and some measures of program engagement, probability of use of on-track services, and number of team members seen. So who uses the C services? Notably, a majority of clients use the services, but not all. About 75% begin enrollment or begin seeing the Cs after enrollment. But those who do seem to begin right away after enrollment. That hasn't been shown consistently in other programs, so it's worth exploring why is it so much higher in this program than others. We find that clients who are not in school and work at baseline are more likely to engage in the Cs, and that's hopefully suggesting a match between the service and the need. We look at the effects on work school participation. We cite the school throughout, I showed the first year here, but we see it through the first 2 years. We see improved employment in the first quarter only. And one possible explanation for that is that, first of all, participants are much more likely to disclose their work with the Cs to a school because there's access to disability services and special education services. And those typically have to be renewed quarterly or renewed each semester. And so it's more, so one possibility is that the C specialist has to remain engaged with the school on a continuing basis. For work, by and large, participants are much more cautious about revealing their work with the Cs or with their work with a program like On Track to an employer, and usually it's typically not disclosed. So the ongoing work with the Cs for someone who's employed may be diminishing over time. I mean, the biggest thing might be to get them into a job, and then after that, it may set that. Furthermore, the access to the social support services can be difficult to obtain outside of a program like On Track. And so I think we're seeing in the quantitative data what we saw in the qualitative data with RAISE, which it sounds like this is something that's helping people stay in school. As we mentioned, it's pretty common in the US to include supported education and employment services. That's less common in international studies, and this might be something that might be of interest to, especially to the international studies. Our limitations: this is a program that's operating only in New York. It's a new and evolving program model. As we said, the new sites are coming up as we've been doing the analyses. Most clients are still enrolled in the program. This is observational data. We don't have a comparison group at this time, though we're looking at Medicaid claims data to develop comparison groups. And it's clinical administrative data, so we're limited to some limitations of data that's available in that. For example, we don't have parents' education. But in future directions, we really want to look at what's affecting the ongoing benefit of school and how that ongoing benefit for work can be maintained. Thank you very much.
Okay, our next presenter is Amy Blank Wilson from University of North Carolina at Chapel Hill.
Hi, everyone. All right, so it'll come up? Yes. All right, so I just want to set the bar really low here and explain that this presentation is going to be very different than the others. This is very early work, and I decided to resist my RCT-loving heart and change the format of how I talk about tiny homes to impress you all. And as me as a scientist, and I'm going to tell you this as a story, which is how we talk about this project. And there's data, and there's lots of great pictures, so just stick with me. Funding acknowledgments, we have a number of funders. They're community foundations. Cardinal Innovations is one of the MCOs in North Carolina who used reinvestment dollars for this project. I have no conflicts of interest. So you'll see that I have these really pretty slides, and I'm going to have a really complicated relationship with them. So if they get off skew, you let me know. First question, some of you might know me, and you say, Amy, you're a mental health criminal justice researcher. Why are you up here talking about tiny homes? And I'm going to tell you, it's a question I ask myself. And the answer actually is really quite simple, because we know that housing is foundational. No, it's not going. There we go. Housing is a foundational component of our health, our community integration, our success. I rant about the lack of it in my research, and when given the opportunity to step up and help, I found I couldn't say no. So what's the dilemma that we're talking about? We all know it, and I'm going to go through it pretty quickly and just show you. I did not make these slides, just to be very clear. I have a great graphic designer who helps. We know that there's a dilemma. Housing costs more than many people with serious mental illness make or have available to them in a month. So they're starting out in a deficit position, and this is untenable. And we also, this isn't a new problem. And we've done a lot of great work, I say, on the first part of the equation. We have a service model that we know works to help people stay and live in the community. And as Kim Hopper said in one article I found very famously, we're not working on the other side of the equation as mental health services researchers, which is building the stock of available affordable housing. Quite frankly, I didn't see it as part of my job description, okay? But this is a real barrier, as we all know, for people, because for supported employment to work, it's premised on the assumption that there's going to be some housing, right? And ideally, it'd be great housing. So I moved to the University of North Carolina, Chapel Hill. I'm trying to get to know people. I'm out and about. If you know the Triangle area, you know that innovation and entrepreneurship happens there at a rate that I've not seen in Philadelphia or Cleveland or the other places that I've been. And one day I walked into the lodge at the farm at Penny Lane where these wonderful service people were talking about this idea of using tiny homes as an affordable housing option for people with mental illness. Now understand something, I didn't have a TV at the time, and I didn't know tiny homes were a thing. And yet, I was in, okay? And then I found about that. I had to get cable, and I found out about this thing. And probably a lot of you think about these options. And you think, well, how could somebody with serious mental illness, with complicating health problems, climb up in that loft? Let's be clear, I'm not climbing up in that loft. So, and I will say this one other thing. My children tell everybody I'm building tiny homes, and then their kids think I'm cool till they find out I'm not doing this container thing, you know, which I think all of this innovation is great. But I want to show you what we're talking about when we talk about tiny home. What if we told you a tiny home could be a 326 square foot house built on a permanent foundation zoned for single occupancy use? Then might we think that this is a viable housing option for people with mental health issues, with a porch on a therapeutic alternative farming community? Because this is what we're talking about. And so pretty much we think about the Tiny Homes project we're working on as a demonstration project, as a proof of concept, as a very small scale attempt at innovation. And we've come to understand that it has 3 phases because it's evolved in front of our very eyes. And you're looking at the first phase. So the first house, which we call the model home, was built at a Chatham County fair in North Carolina through a partnership between XDS Services and Habitat for Humanity and a lot of other people on that sign. And they built that. They moved it down a road, down a private lane to the farm. And then it now sits on the foundation that you see. So this was the first part of it. And this is about when I entered the picture. And Tava Mahavadan, who is the director and the founder and the person, the engine behind this innovation, he's worked in services for 30 years, and he knew that to get research embedded early in this to help inform the design by going to consumers, the end users, and other stakeholders like service providers and policymakers, and getting feedback on what can we learn from this model home to help inform the design of the village that he's always envisioned building of tiny homes. That's where I came in. And I said, sure, I'll try. And we got the first grant we tried for, which was the C. Felix Harvey Award, which is a unique award at Carolina. Carolina very much deals in entrepreneurship, and this was an award to fund potentially high-impact, unfundable projects. I said, you got to come talk to us because that's us, and they funded us, and that allowed us to conduct research using this first home. So this is just a look at the inside of our model tiny home, just so you get a sense. It has a bedroom, it has a bathroom, it has a kitchen, it has a living room. It looks like a home. So we used a number of different techniques. It's a process evaluation that's built into the development. And we did focus groups, 2 with service providers, 2 with consumers. We did overnight visits. I got to host 8 overnight visits last summer where I spent time with individually with people who were consumers of the center that's sponsoring this. There goes my water. The center that's sponsoring this, and I interviewed them before and after, and we used a lot of different measures and collected a lot of information, but we're deeply interested in their understanding of what it was like to live there and what we could do better. And then we also talked to policymakers, and I did key informant interviews. We also have a universal design because somebody on our team is an occupational therapist. So he went through and did a full assessment and created a blueprint of what we'd have to do to make this home fully accessible to people of all physical abilities. All of that is informing the design, but I want to stop and just talk about some of the feedback that we got from about what we could do related to the design of the home, and then the design also of the community that we were asking them about. And you're going to see some overlap here, and there's a couple things I want to point out. By and large, almost every consumer I brought into that house, and I was present for all of it, said to me, "You think this is tiny? You should see where I live right now. This is a palace," right? And not only that, it offered them benefits that they didn't want to even dream about: stability, cleanliness, connection to community. There were a number of other benefits for the home, but tiny is not tiny. Mark Sulzer is the one who got me to go from saying tiny isn't tiny to saying tiny homes are huge for people with serious mental illness. So I got to give him credit for that idea. You know, and we talk a lot. There's a lot of things that people agreed on and some things they didn't. And the things they agreed on were the needing of natural light, that these are not individuals who are looking to live tiny, like this movement. These are people who are looking to live in a stable home where they have basic amenities like everything else. So they want a drawer for their silverware. They want a small dishwasher, right? So there are some differences. You know, we're not trying to build tiny homes, right? We're trying to build affordable homes and using this model to do so. They love the natural light. We couldn't get enough of it, and we have a lot of it, and they wanted more. And you'll see how we built that into our design. And also, there was a lot of discussion of entertaining. Yeah, and this was another thing that, to the point, like, well, can I have somebody sleep overnight? Am I allowed to have a double bed in this house? We didn't build the room big enough for that, I'd like to tell you, right? You know, so there was a lot of ways in which that we started to think about how people would use the space and what was important. And then there also was this idea of being able to live in a home by themselves without a roommate, without a connecting wall, right, to the next apartment, that was what that people called invaluable. And both the providers and the consumers agreed on that. What they didn't agree on was how to use the space. There was a lot of that kitchen's too big, that living room's too small, it should all be about the porch. And what we took from that, thanks to the architects who I work with on this project, by the way, there's this thing called Engaged Design, you all probably know about it. I didn't know about it. You'll see we use these, what they call utilitarian open floor plans, where the space is flexible and can be customized to the individual preference. So then we did also talk to people, well, so if we built a community of these homes, and I want to define what we mean by that. 17 is the magic number. For those of you who understand policy, we spent a lot of time figuring this out. So this is a home of 15 tiny homes, 5 of which are set aside for veterans living on a fixed income. So it's a total of 15 homes. That's as big as this community is ever going to get. So you might say to me, Amy, well, why are you up here talking at all? One of the things that the C. Felix Harvey funded is a how-to manual. And so one of the things we hope to do is we're in the process of finishing up a website, and so we can create a virtual learning community, because we want people to learn along with us. We're trying to make this process transparent so other people can learn the lessons with us and hopefully feed back into us lessons they learn as they try to use these models in different places and with different populations. Now, having said that, when we talk to people with mental illness about what would it be like to live in community with each other, you know, if you so chose to do that, there are a couple really important things that came out, both actually in the home and the community. Connectivity. People are much more wired up than I thought. And maybe it's just me. Remember, I didn't have a TV. I didn't know about tiny homes. So, but they really want access to streaming. They want access, good cell phone service. They want to stay connected digitally. That is a way in which people think about connectivity. So that matters, because you've got to think about that if you're building a community and how you build the infrastructure for that, right? Another issue that really became what I call a sticky wicket is how the home should be faced. And the providers wanted to socially engineer it so that we could enhance community, and the consumers wanted a wagon wheel where everything faced out, or better yet, the houses weren't next to each other and they had privacy. So there was a lot of back and forth on this, and you'll see how, again, the architect helped us deal with this. And finally, and I really want to make this point, we've struggled with what to call this community. We started out with intentional community, which was unintended and had some unintended consequences, because we didn't mean it in the way that Medicaid excludes. And finally, somebody said to me, we want to live in a planned community like everybody else does these days, that has walking trails, that has a clubhouse, that has an HOA. We want to say in what happens to us. And so one of my doctoral students says they want to live in a resource-rich community designed to promote well-being. I was like, you're right, that's exactly right. So we're building this through a public-private partnership. Tava's vision is to engage community providers. Very quickly, to blow through these slides, just understand, I thought I was done at the end of the research. And I said, I'll come back the next time I need a researcher. And then, like, he just never kind of let me leave. And then one day my husband said, are you, like, building this village? Like, I'm just curious. And I was like, I think I might be, right? You know? And so now I'm the co-director. And why that is because in this public-private partnership, I, as a university researcher with, like, maybe some people see me as an expert on mental health services, provides the credibility and really, you know, the scholarship behind what we're doing. Tava is a man on the ground who makes everything happen. And when we go to funders and we talk to them, we both have to be at the table for this to work. So we are in phase 2. I'm going to show you the slide. My favorite slide. I'm done with phase 2. We're zoned. Yes, we are zoned, thanks to Tava Mohammedan. We are ready to go. And I'm not talking about soil anymore. I don't care. I have met a lot of civil engineers and environmental scientists, and they're really good people. But you see that cat? That's me. I phased out for right now. But next week, we're going to start talking again to the architects, and I'm back in. Just want to show you the stages of excitement and grief around funding for this. We have actually been successfully engaged in an international organization and foundation, and we're going to hopefully receive significant funding. This thing is actually happening. So I'm actually now back to the oh no phase. And so what is this thing that's actually going to happen? This is a rendering from our final architect. This is what you can look at, what the community will look like. If you see those houses, it's called a pocket neighborhood. He solved the problem of facing and distance by the way in which you can have houses fairly close together, yet you're not looking at your neighbor, because the biggest thing people were saying is, I can't let somebody else's bad day be my problem. I work hard to keep my sanity, right? So there's a lot, and those are direct quotes, right? So, and we never even considered this design aspect as a possibility. You'll see there's a clubhouse that is going to be funded through undisclosed partner to date. I mean, it's not a secret, it's a bank. You know, and there's going to be an amphitheater, and there's going to be parking, and it's connected. And here's the home. So look at this. A tear came to my eye the day I saw this. The architect took everything we told him, and look how different the design of these homes are. These will be the 3 floor plans. The biggest issue is to make it fully handicapped accessible, because that does, you know, you make it bigger, it gets more expensive. So there are 3 different floor plans. They've integrated everything we've talked about: light, open floor plans, the use of outdoor space. It's really amazing. Bottom line is $50,000 to build these homes. And we're going to do it through a public-private partnership, so people will pay $260 a month, and that will maintain the community and the homes that they're living in. That is a massive change. And the last thing I'll just say very quickly is we aren't just plopping this anywhere. It's going to be at a farm where there's lots of alternative therapeutic farming community that's part of a mental health center. And there's going to be a lot of opportunities, but no mandate for people to participate in daily activities and access to services and healthcare that are right there. And I just leave you with this very question, because my time is up. I want to challenge us all to start to think, because through this process, John is here, maybe here. No, John had to leave to get on the megabus. My doctoral student said to me, I said, well, maybe we need to start thinking about housing as the primary intervention, one of the primary interventions, rather than support. And I've been thinking about that a lot, and I invite all of us to think about that as well, and what we would do differently. Okay, thank you.
Okay, batting cleanup here. We have Ryan Doherty from University of California, Los Angeles.
And do I just click this?
Yes.
Oh, great. Okay. Hi, everybody. My name is Ryan Doherty. I'm here to present to you today the rationality of reliance on services, rethinking community integration, and therapeutic termination in mental health services. So the concept of community integration has been key to mental health policies post-deinstitutionalization. It's this concept that people have a right to receive mental health services in the community, and that people should become self-sufficient in the community through housing and employment. Of course, there have been many barriers to community integration, two of which I'd like to focus on today. So that would be people's experiences of crime victimization and experiences of social stigma, both of which are correlated with lower outcomes and lower rates of community integration among people with SMI. And of course, as we talked about today, there are a lot of consequences to this. So we see high rates of poverty and unemployment. We see high rates of homelessness, which is feeding into a cycle of mass incarceration. The good news is that when community integration is done, it's associated with really positive outcomes, both clinically and in terms of social connections. So the purpose of my research project and the research project that my team is conducting is to think about some of the barriers to community integration. And so today I'll be focusing on victimization and stigma. And our hope is by understanding some of these barriers, we can begin to rethink community mental health services to address these barriers. So the research questions I have for you today are, one, what are the experiences of people in mental health services in relation to safety? And two, how do experiences of safety shape their experiences with community integration? Our methodology was informed by constructivist grounded theory. Like other grounded theory approaches, researchers use data to build up towards a new theory to explain a social phenomena or a process. We use semi-structured interviews. This is actually part of a parent study, a multi-site study on community integration. Constructivist grounded theory really focuses on people's interpretations of their lived experiences. And what we saw in the data in New York is that people really were concerned with safety. And so when we started the project in Los Angeles, we really focused in on safety to follow this theme. We also, along with the semi-structured interviews, we did a social network analysis where we asked people to name to list all the people that they've spoken to in the past 2 months. And then that would allow us to more specifically talk about the individual relationships they might have with family or friends or treatment providers. The analysis is a process of memoing each interview, looking for patterns by organizing the data, categorizing the data, drawing diagrams. And what we ended up doing was categorizing people's safety experiences. We pulled quotes and we looked at what are their experiences of safety in the community, outside the community, different types of experiences related to safety. And what was really nice too is we could triangulate some of this qualitative data with the social network maps that we had created. As I said, it was a multi-site project. It was informed by the Los Angeles practice-based research network, which Aaron Kelly spoke about today. In order to be in the study, they had to be in services for more than 2 months, be between the ages of 18 and 65, speak English, and have a diagnosis of a severe mental illness. These are our demographics. We began to reach saturation at 20 participants, meaning we were seeing repeated themes in the data. We're still collecting data to pursue other themes we're seeing. Participants were around the age of 42 years old, 70% male, equal parts black and white, and 4 Latinx participants. So here are our results. So people had really different definitions of community. Sometimes it meant direct connections with friends and family members. Other times it was geographic. So the relationship to Los Angeles or Long Beach or Inglewood. Sometimes it was about social spaces. So my church is a community. My school is a community. Importantly, people talked about their mental health services not as services, but as a community in itself. People also talked about safety in 2 different ways. So one was about physical safety and violence, and the other was about psychosocial safety and experiences of interpersonal stigma. What we found in the data was that people were constantly evaluating their own sense of safety, and we named this theme Navigating Safety, and we used this theme to understand the ways in which people might navigate safety in different contexts. So I have this pretty little diagram for you here. So this purple represents outside community experiences. And by outside, I mean outside of their mental health community. And what we found in terms of navigating safety is that people were encountering unsafe spaces. But at some point, they joined mental health services. So inside their mental health community, they felt like they were securing a sense of safety finally in their life. And what you'll notice is that purple box encompasses That blue box there, meaning they're still encountering unsafe spaces while in mental health services. It's just outside the boundaries of their mental health services. So when they're walking home at night, as an example. This is when the interview is being done. So let's look at each of these boxes. So in terms of encountering unsafe spaces, people had the sense that there was constant gang and police activity around them at all times. One participant remarked, all day long you hear fire alarms and police helicopters and sirens. People talked about experiences in regards to their physical safety. So many participants talked about experiences of robbery and theft, street harassment, and physical and sexual assault. People also discussed at length their experiences of stigma. They experienced a lot of stigma from friends and family. One participant who was kicked out of his family essentially described his experience as nobody wanted to be bothered with a crackhead. And also people experience stigma not in terms of their interpersonal connections, but also just in public spaces. So public transportation, for example, was a place where people felt like they were being discriminated against a lot. And these experiences resulted in people wanting to distance themselves from people in their local neighborhood. So consider this quote here. This is a participant who was talking about a community he used to live in South LA. Well, really, I really didn't talk to people over there very much because there's gangbanging over there. So I didn't talk to them too much. I'd just be like, hi, and going in the house or whatever like that. But I didn't even want to start talking to them, you know, because I didn't want to get caught up in no kind of drama or anything like that. Inside their mental health community, they talked about the sense of securing safety. So people described their mental health communities as really warm and welcoming, a place with unconditional love. Actually, a lot of participants talked about their mental health community as family, as a second home. What's really important is that people were contrasting their experiences in their mental health community with all other communities. One participant described their mental health community as a sanctuary, as an option to get away from the difficulties in the world. Consider this quote. I come down here for a few hours, and it's nice being down here because basically people know why you're here. I don't have to pretend. When I'm in society, you have to play along with the rules of society. You can't do this, you can't do that. But when I'm here, you know, they know why you're here, you know why you're here, so everything's a little calmer. So what we're proposing here is that these experiences are actually quite informative to how people think about their future communities. People want to continue building the sense of safety that they have finally found in their lives in their mental health communities. This looked like two different things. So some people talked about this idea of community integration. They talked that they wanted to transition to normal life society again. But people also wanted continued involvement in their mental health services. And this looked like two different things. So one, that could be ongoing services as a client, because people are scared that it's difficult to replace the sense of safety that they found in their mental health community. Also, other folks had concerns that because they have a severe mental illness, that they will always need support, that sometimes you might be incurable. Other participants talked about no longer wanting to be a client at their mental health community, but to give back in a new capacity. So many of our participants were in the process of becoming a peer advisor, expressed interest in becoming an AA or NA sponsor, and one participant talked about wanting to become a social worker, which made me feel pretty proud. And this was summarized in one participant who says that they want to give back what they've been taught. So what does this all mean? So in the past, people have reported feeling most integrated with their mental health community, and that their mental health identities are really informative to how they think about community. What we're seeing in this data is that services are a community for securing safety, and that this experience of safety is forming a new idea of what's possible in their life, the possibility of actually being able to feel safe. And this could look like forming new communities out in the community, but what we're seeing across the data is that people wanted to continue to be involved in their mental health community. So what's the rationality of reliance on services? One, it is very rational that in light of people's experiences of violence and stigma and the broader context of feeling unsafe in their community, this reliance on services might actually be a protective strategy. And secondly, recovery for clients is beyond clinical symptoms. It's a process of rebuilding a sense of safety in their lives. There are a few limitations to this project. So, of course, it's a cross-sectional design. We are interviewing people at a very specific point. It would be really interesting to look at how these ideas and these interpretations change with time. We are mostly interviewing middle-aged and older adults. We just began interviewing younger adults who have a different relationship to social media, their dating apps, and Facebook and Instagram, and that might shape the ways in which they think about community. And we've only sampled people in services, so it'd also be interesting to consider, how does safety play into the receptivity of services in the first place? I want to acknowledge my, the research team that I'm part of, and different consultants, and of course the LA Practice-Based Research Network. References. Great, thank you everybody.
So when we put together this panel, we did have some questions about how well it might hang together or not, but I actually feel, of course I'm biased, I feel it hung together very well in terms of spectrum of thinking about the modes, timing, type, place, duration of community supports and community services. And I think we might be really early on in understanding what that means about outcomes. But I want to open it to any questions from the audience. Phil, come to the microphone, please.
This is for Ryan at the last presentation.
Is that mic on?
Are you hearing me?
Is the mic on?
I can.
We can hear you.
Yeah.
In our research, we found that the perception of local stigma were related to what kind of housing. So people who live in green category housing perceive less local stigma than people who live in ugly housing in the exact same neighborhood. So I was wondering what type of housing people were living in, and if that's something that I know it's a small sample, it's qualitative, but it's something that came up in the. So basically, what we took from it was that if you're living in congregate housing, you know that everybody knows in the community that you have a mental illness, and you kind of perceive how people are acting toward you differently. Maybe they do act toward you differently because they know something about you that you haven't really revealed, but they just know it. So how did that come up, if it came up, and what kind of housing were people living in?
Yeah, that's a really great question. So a lot of our participants are living in housing that's provided by their services. Certainly there's a sense of psychosocial safety in that, like, I'm not going to experience stigma because everybody, maybe it's on another slide that I didn't present today, but someone said, well, everyone knows why I'm here. And I know that someone said that about the services, but it was also about the housing. But participants also expressed concerns about their physical safety around other clients, and that sometimes clients might have outbursts. And actually, I think the quote that you spoke about of people being really protective about their own well-being and not wanting other people's bad days to impact their bad days as well. So yeah, I think we're seeing something similar. It'd be interesting to also dive a little bit more into physical safety as well.
But it sounds like everybody was in some kind of a congregate setting.
For the most part, there are some folks who were living with family members. We actually had some folks who were living in LA has like a lottery housing system for homeless folks as well, which is interesting because in those sort of settings, people didn't feel that sense of, even though they were sharing the space with other people who've experienced homelessness, they also were concerned about stigma because they also had this added identity of receiving mental health services. But for the most part, yeah, people were in some sort of transitional housing.
Okay, thanks.
Yeah, thank you.
Here comes someone.
Yeah, sorry. Hi, I have a question for Leisha. I loved your presentation. I was really shocked that benefits didn't come up as one of the potential hesitancies or difficulties about self-employment. Is somebody like that's what would prevent me from probably pursuing self-employment, or something that would be way on my mind. So I'm wondering if you could comment on that. Or
Yeah, I think there's two things in the data that, one is that, remember, 25% or 27% were reported lifetime benefits, so it might just be a small proportion. of the sample. And then the other thing is the part-time work, and I think that's one of the benefits of self-employment is that you can control your income and hours. So I worked when I was on disability. I had to talk to my supervisor about not working too much. They wanted to increase my hours, and I couldn't. But you have less control over your hours and your income when you work for someone else. So it might not be an issue because it's a natural accommodation.
Sure, we will. I have another question for Leisha, by the way. The people on the video cast can only hear us when we're speaking into the microphones.
Oh, okay. Good, it was top secret.
I think you said also that there was, in your group, there was low use of supports for running the business.
Yeah.
Right? Thoughts on that?
I think there was sort of like a diversity of different supports that people reported as being helpful. So it seemed like the informal supports people accessed more and found helpful. So talking to other business owners. And then, so we have some open-ended responses in the survey that provide some light onto some of the results. So like people said things like, I would like to use business coaching, but I can't afford it. And then, like was pretty low uptake of using a small business development centers, which are free to anyone in the community. But there's like other research on disabilities to suggest that that the small business development centers themselves don't prefer to work with these very small businesses that are operated by people with disabilities. And I think there is some work about sort of educating those folks about working with people with disabilities, either because they're small or because of accommodations.
Okay, another thought I had just as we were hearing from everybody is maybe there'll be a day where these won't be separate things that we're talking about here, and there'll be more sort of a blending of not just the services and supports, but kind of the idea of what life is like for people with mental illness.
This question is for Ryan. It's probably a quick question. I think I understand what the answer would be regarding the importance of being in a mental health community, but I don't think you touched upon therapeutic termination, or if I missed it. So I'm just curious, was it a constant fear that, so yeah, I just wonder if you can just expound on that a little bit.
Sure, absolutely. Participants reflected upon a fear of having to leave services one day. I had one participant who was actually explicitly told by his provider that his time at the wellness center, he's there too much and he needs to think about leaving. And she was trying to get him to get into employment and housing, and you should go to the senior center, and it was totally devastating for him. And so I think one thing that I would like us to all think about is certainly we don't want people to be in mental health services forever, but there might be new capacities in which that person could stay involved at that community mental health program, but without having to necessarily, kick him out the door, I suppose, which is how he felt. So.
Can I ask Ryan a question? Well, so I was thinking when you were talking about I've done quite a bit of work with the consumer survivor movement. I don't know if everybody's sort of familiar with that or if you are, but yeah, and thinking about, a lot of those people are out of services, but that there is a community there of people who have had the same experiences, and also sort of like retaining people in the work, and maintaining that community. But then, I don't know, is the ultimate goal that people are sort of totally disconnected from from mental health?
Oh no, I think what we're seeing in the data and what participants are asking for is some sort of acknowledgement that people want to stay in their mental health communities, and that there needs to be a way for the providers and for policies and systems to be in place that don't make them feel like they need to leave this place that's safe for them.
So that's very interesting because the farm where we're building the tiny homes village, it's an alternative community, and it minimizes the differences. We work actively to not use titles and labels, and what you see there is a lot of people who are in occupational roles have lived experience and have, remained connected with the community, and they move into roles as professionals and leaders in this community. And it's one of the few places I've seen where that's a fluid process that happens without saying, I'm going to flip your name tag. So it's really an interesting model, and I just wonder if that's something that you see at all. Because they specifically do not call themselves a consumer space, right? They're just saying this is a space for people of all abilities, and people of all abilities can be engaged in meaningful activity, and they create a lot of opportunities for different ways for people from different walks of life to come together.
Yeah, no, I actually was thinking while you were presenting, like, oh, I wish I could send, the hundreds of people I've interviewed, to this. And I think one thing we need to keep in mind is, especially when we do qualitative research, is we don't necessarily take every answer like quite literally. Like it doesn't, like I don't think we should take these responses as, oh, people should be in mental health services forever. We can interpret what they're saying, and what we're seeing is that people want safety. And that's like a really human, basic, like Maslow's hierarchy of need. I don't see, and I'm new to LA. I haven't seen anything like that in Los Angeles. But I do think that the people that I've interviewed and what I'm seeing in the data, that would totally fit those needs that people are talking about.
There are a couple counties in California that are working on that, but I don't think it's specific for people in the mental health system, but because obviously we have a huge housing crisis. But I know Sonoma County and even San Luis Obispo are working on tiny homes.
Right. It does seem like another theme, though, is people wanting to have some evolving in what their options are based on their preferences and their capacities, and that might be a fluid thing. But for it not to be static, like, okay, you've achieved this and this is what it's going to be like for the rest of your life. Okay. Yes, Andrea.
Okay, again, let's. Very nice, and it was very interesting to see different approaches and how that can add on. Any of those data you also have follow up in a sense of see how that can help them also definitely to reduce hospitalizations and mental health outcomes. So I'm wondering if any of you have something to share.
Well, we have big dreams. I can say once we have people living in the homes, and yeah. So and actually the center that is connected. I mean, this is a very this is a very resource-rich approach in many ways, and we track health outcomes, and we will track all the typical health outcomes. I also work with Mark Sulzer, and we actually hope to study community participation patterns and use some of the methodologies that his center has developed in probably a case control design, so we can really empirically answer questions like creating a community for and of people with mental illness. What impact does that have on how they spend their time and where they spend their time? And again, this is 15 people. This isn't going to answer, the questions for everybody. But there's a lot of stigma around. We encountered a lot of very harsh messages in the beginning, around the idea of creating a community for people with mental health problems. So for obvious reasons, these are very good reasons, and we need to be very thoughtful about it. And I think we also need to study their empirical questions, right, that we need to follow.
Okay. Well, I want to thank the panel for a very interesting presentation and thank the audience for your great questions.